In this series, we've been looking at the dorsal apparatus of the human finger to develop an appreciation of the exquisite interplay of forces that creates motion of the human finger. One of the primary participants in digital motion are the interosseous muscles. And even though we tend to group these together along with the lumbrical and call them the intrinsic muscles, they are far more detailed and intricate than I believe most of us give them credit for being. So it's our hope that this 2-hour presentation will provide you a greater insight into the differences of the interosseous muscles, not only from each other, but also how they act different from the lumbrical, which we will cover in the presentation to follow. The human finger, and in particular the small intrinsic muscles that insert into the dorsal apparatus, have a very high variability of anatomy. And I believe this is one of the reasons that you and I have not been taught this information in any great depth, because it's somewhat elusive because of this variable anatomy. So I would remind you again that it is very important, as we're talking about the specific anatomy and what the muscle is doing, that your focus be on learning the concept of what we're talking about, rather than assuming that the hand that you are seeing is literally the same anatomy as what we're presenting. It's much more important, I think, to walk away from this presentation understanding the overview. Let's start with the anatomy of the interosseous muscles, both the muscle and the tendon anatomy. If we look down on the dorsum of the human finger, here is the wrist, here are the metacarpal phalangeal joints. The extensor tendons have been incised and removed so that we have a clear view of the periosteum of the bones of the dorsum of the hand. We clearly see here how the dorsal interosseous muscles originate up to almost the midline of the dorsum of the bones. They don't interconnect, but they do have an origin that extends to the dorsal aspect. Later, when we look at the volar interosseous muscles, we'll see that they do originate more volarly. But I find it very confusing that these muscles have been named dorsal and volar interosseous muscles, because as these muscles move more distally away from their origin, they lose this dorsal volar orientation, and they become structures that approach the metacarpal phalangeal joint and the dorsal apparatus in very similar, if not identical, manners. They do so on the opposite sides of the fingers. They don't do this together on the same side, but their function in terms of what motion is created from the dorsal and the volar interosseous muscles are, in many cases, identical. We will clarify this as we move through this presentation. The muscles are called interosseous muscles because obviously they are between bones, inter meaning between and osseous meaning bone. These muscles are contained on two sides by the bones from which they originate, the metacarpals of the hand. In this cross-section from a book by Dr. Roy Mills, which is approximately just proximal to the metacarpal phalangeal joints and closer to the shaft of the metacarpal bones, we see the cross-section of the entire hand with the fingers here and the thumb here. In green, we've highlighted the dorsal interosseous muscles, with the first dorsal, as we'll discuss, being significantly larger than the other groups of interosseous muscles. Here we've grouped them together, the dorsal interosseous muscles, although they do have distinctly separate muscle bellies. The volar interosseous muscles, being 3 in number as compared to the 4 in number to the dorsal, are seemingly somewhat smaller. And they are here in this aspect where you're seeing the muscle belly, they are indeed more volar. When looking at this cross-section, it should be readily apparent that the bulk of the mid portion of the hand relies on innervation of the interosseous muscles, because these muscles, although the fibers are very short, the muscles are of significant cross-section, therefore giving us significant strength for their size. The volar interosseous muscles. Here, this is a dorsal view, so we do not see the volar origin. We're seeing them come from the volar aspect, moving dorsal to insert into the dorsal apparatus. There are only 3 volar interosseous muscles, and it is rare that a volar interosseous muscle exists to insert on the long or middle finger. The dorsal interosseous muscles have 2 bellies. These bellies arise from adjacent metacarpals. One of the metacarpals is the same as the finger on which they insert, and the other metacarpal is the adjacent finger. These 2 bellies insert differently and therefore have different functions. Again, we will clarify this as we move through this presentation. The exception to the dorsal interosseous muscles is the significant size of the first dorsal interosseous muscle, as well as its origin on the metacarpal of the thumb, which is a greater distance away from the second metacarpal than any of the metacarpal distances of the metacarpals of the finger. So the first dorsal interosseous does need to be considered somewhat differently than the other muscles. Again, in cross-section, we see the first dorsal interosseous muscle significantly larger and covering a larger span between the bones than we ever see the other, both dorsal and volar interosseous muscles. In this illustration, the lumbrical muscles are not illustrated. They're not highlighted. If we look carefully, we can see them here adjacent to the profundus tendons. The comparison of the cross-sectional size is significantly different between the lumbricals and the interosseous muscles. But if we look just between the dorsal interosseous muscles in green and the volar interosseous muscles in blue, we see some difference in cross-sectional size, but it's certainly not as overwhelming as that in comparison to the lumbrical muscles. The interosseous muscles of the hand are what allow us to create the arch and maintain the arch of our hand. As we know, during finger flexion, particularly the little and ring finger metacarpals descend volarly, creating a much greater curve to the arch. In hands that have a denervation of the interosseous muscles, we see the inability to create this arch, in large part because the ulnar nerve, which is responsible for innervation of the interosseous muscles, also innervates the hypothenar muscles, which are responsible for flexing that 5th metacarpal forward toward the palm. In these 2 comparison cross sections, one here on your right, just ever so slightly proximal to the joint, some going through the joint, versus a bit further proximally, we see some striking differences. We see that very distally, as you're approaching the metacarpal phalangeal joint, we see much less of the muscle. We're obviously into the joint on the little finger, and we see no muscle. We now see tendons around the joint. Versus on the radial side, where the metacarpals are longer, we still see some vestiges of interosseous muscles as they approach their insertion. Further proximally, we see cross-section of the interosseous muscles much more clearly, and we also see the beginning of the long adductor muscle which spans across the palm of the hand. Here we're too far distal to clearly see the adductor. We see just a few fibers here. Again, we see the lumbrical muscles here in small cross-section, also approaching their insertion, but they are only ever so slightly larger in this more proximal cross-section. The interosseous muscles create the bulk of the hand. The only other bulky structure are the bones, the metacarpals themselves. The arch is controlled by the interosseous muscles. Here is a volar view of the palm. You see that the flexor tendons have been removed from their sheath. Here are the metacarpal phalangeal joints. We actually see the head of the fifth metacarpal here. We do not see the thumb in this view, which would be here. And what we're looking at are the volar muscles, which are arising from the metacarpals on the volar aspect, but we're also seeing some of the dorsal interosseous muscles. Because remember, there are only 3 volar interosseous muscles, so this cannot only be the volar interosseous muscles. In the volar view, you are able to see both volar and dorsal interosseous muscles, but in the dorsal view, you rarely would see the volar interosseous muscles. Of course, to see these, you have to have the flexor and extensor tendons removed in order to directly look at the muscles. Here we look at the anatomical drawing of the dorsal and the volar interosseous muscles. We see clearly in this illustration that there are 2 muscle bellies that make up each dorsal interosseous muscle, but that there is only 1 muscle belly for each of the 3 volar interosseous muscles. Just to remind us that all of the interosseous muscles are innervated by the ulnar nerve. So it's a rather devastating injury when the ulnar nerve is denervated, because not only are all of the important interosseous muscles lost, but also the important muscles to the little finger, as well as that huge adductor muscle and part of the flexor pollicis brevis. So if we look at an ulnar nerve injury, we look at a loss of the very important muscles that control movement in the fingers. Although the lumbrical muscles are absent on the ring and little fingers, usually the lumbrical muscles on the index and long fingers do remain intact. With an ulnar nerve lesion, when we see a loss of all interosseous muscles on all 4 fingers, but remember the lumbrical muscle is intact usually on the index and long fingers because they're innervated by the median nerve. There is, however, a loss also of the lumbricals on the ring and little fingers because they're usually innervated by the ulnar nerve. So on the ring and little fingers, there is a loss of both all interosseous muscles as well as the lumbrical muscles. The presence of the lumbrical muscles on the index and long fingers usually prevent them from developing this classic claw position. They usually have just enough power to prevent the clawing. However, there is an entity called tardy ulnar palsy, where over time the lumbrical muscle is not strong enough to prevent this clawing motion, which really is just an over-accentuation of the power of the extensor digitorum communis. And a very late presentation of ulnar palsy may indeed demonstrate clawing of the index and long fingers even when the median nerve is intact. When the median nerve is absent and the lumbrical muscles of the index and long fingers are absent with this median nerve injury, obviously the thumb is very involved with significant loss, but the index and long fingers usually extend fairly normally. with the presence of the interosseous muscles. Remember, in the index and long finger, with the median nerve not working, these two fingers have normal functioning interosseous muscles, but not functioning lumbrical muscles. We can see here that this individual appears to more readily extend the ring and little fingers than the index and long fingers. Perhaps this is related to the median nerve injury. Perhaps there was another direct trauma. This individual is a person in Nepal who has leprosy. It is very common in leprosy or Hansen's disease for the ulnar nerve to be most commonly involved, which is indeed the case with this woman. Her median nerve is intact, as you can see a normal configuration to her thenar muscles. But you can see significant flexion contractures of her fingers with an inability to extend because of the loss of the interosseous muscle function. It's important to remember when thinking about the interosseous muscles that not only are they contained by bone on two different sides, but they also are contained dorsally and volarly by fascia. They are within a very tight, unyielding compartment, fascial compartments, and for this reason, the interosseous muscles have a very difficult time when there's trauma to the hand because edema within the fascial compartment doesn't have anywhere to go. And the interosseous muscles are greatly affected by the presence of edema, limiting their ability to function. Therefore, it is extremely common in the presence of any trauma to the hand with the creation of edema in response to the trauma, that the interosseous muscles become adaptively shortened. They don't have room to stretch and elongate and to move normally or to contract because of the presence of the edema within the fascial compartment. The next presentation in this series specifically talks about testing and treating interosseous muscle tightness. In my opinion, interosseous muscle tightness is a far more significant influence on limiting finger flexion than we as clinicians often identify it to be. Here's a view, a really exquisite view from this image from Dr. George Bogomil showing us the interpalmar plate ligament. You can see the structure that is going from one volar plate to another. Now remember, the volar plate is the posterior aspect of the A1 pulley. So the A1 pulley and a portion of the sheath more distally has been incised and excised so that we can see into the flexor tendon sheath and appreciate the connection of the volar plates. Although these structures are most correctly called the interpalmar plate ligaments, it is not uncommon for them to be incorrectly called the intermetacarpal ligaments. This is incorrect because they don't connect the metacarpals, they connect the volar plates. If I were to ask you this question, what is the primary function of the interosseous muscles? Now, primary function. You would more than likely say ab and adduction. I certainly would have said that because this is what they are responsible for, and there are no other muscles that create the ab and adduction. But they also have another primary function, which we will discuss. As we look at the anatomy and appreciate the location of the interpalmar plate ligament, dividing here the lumbrical insertion, which is volar, and the interosseous insertion, which is dorsal, we can appreciate that the interosseous muscles approach the dorsal apparatus from a very different angle and into different fibers than that of the insertion of the lumbrical muscles. It's my hope that reviewing this presentation, as well as perhaps others, gives you a much clearer differentiation of the function of the interosseous muscles versus the lumbrical muscles. It is so common that I hear therapists say the intrinsic muscles, not truly appreciating how very different they are and how their influence is very different. The axis of the MP joint, however, in relationship to the insertion of both the lumbrical muscle and the interosseous muscle, is consistent. The axis of the MP joint is always dorsal to the insertion of both of these muscle tendon groups. This means that both the interosseous and the lumbricals do have some ability to flex the metacarpal phalangeal joint because they are below the axis at this joint. We will clarify that further as we go through the presentation. Now, as we said, we usually think of the volar interosseous muscles as being AD or adductors, and the dorsal interosseous muscles abducting the finger. But if we look truly at the insertion of these muscles, it now becomes actually, in my view, rather confusing. Although the volar interosseous muscles are indeed on the side of each finger to be able to bring the finger toward the midline of the long finger, they have no bony insertion. In other words, the volar interosseous muscles all insert into the dorsal apparatus. Well, if they insert into the dorsal apparatus, it's very difficult then for them to be pure adductors because they don't have any insertion specifically just into the proximal phalanx, which would create a pure adduction. We do see, however, in the dorsal interosseous muscles that there are specific bellies that just insert into the bone. These bellies that do insert directly into the bone are pure abductors. They have no influence in the motion of the entire finger. They only influence motion at the metacarpal phalangeal joint. This can be demonstrated fairly easily if you will place your hand flat on the table, don't press down, but just place your fingers flat. Now, abduct all of your fingers. Try not to lift your fingers off the table either. Resist the abduction of your fingers and gain a feel for how very strong your abduction is. Now, with your hands still flat on the table, adduct your fingers. Be careful not to flex them or push into the table. And try to now spread your fingers, and you will see that you have very little ability to maintain your fingers in adduction, particularly when your hand is flat on the table. Now take your hand off the table. Put a sheet of paper between two fingers, say the index and long finger. Do not allow the metacarpal phalangeal joint to flex, but keep your fingers in neutral extension. Adduct to hold the paper and try to pull the paper out. You will not be able to adduct enough to hold the paper because you have no volar interosseous muscles that are inserting into bone to be as strong with adduction as with abduction when the dorsal interosseous muscles are being active.